myself, Dr. Joseph, in Department of Conservative Dentistry and Endodontics. Today we will be discussing about the topic diseases of pulp. Earlier we have seen the etiology of different diseases of pulp. Today mainly we will discuss about the classification and in that mainly inflammatory diseases. The two most important inflammatory diseases, that's reversible and irreversible pulpitis. What are the difference in symptoms, histopathology, radiological features, and treatment part of reversible and irreversible pulpitis? Pulp degeneration, necrosis, and two inflammatory conditions, that is the chronic hyperplastic pulpitis and internal resorption, we'll try to cover in the next session. So coming to the classification, according to Grossman, 14th edition, the pulp diseases can be divided into either inflammatory or degenerative or necrosis. In the inflammatory diseases, it can be divided under reversible and irreversible. Under reversible, it can be symptomatic or asymptomatic. And irreversible, apart from the symptomatic and asymptomatic, there is two more conditions called chronic hyperplastic pulpitis or otherwise called as pulp polyp or pulp hyperplasia and internal resorption. And the remaining pulp degeneration can be of calcific or fibrous, which is revealed mainly in radiographic or histopathological diagnosis. And necrosis is also under the new edition. They have divided again necrosis of the pulp into pulp necrobiosis, where partially pulp will be vital and partially non-vital. Then pulp necrosis with or without signs of infection. So coming to the main inflammatory conditions, that is reversible and irreversible, what are the differences in the clinical presentation, radiological presentation, histopathological presentation, and treatment part that we'll be discussing in this session. So pulpitis or inflammation of the pulp may be acute or chronic, partial or total, and the pulp may be infected or sterile. Mainly, when you hear the name reversible pulpitis, that just means that the inflammation of the pulp, the condition, where when you introduce a stimulus, the patient will have symptoms, and when you withdraw it, immediately the patient will be relieved of the symptoms and the pulp goes back to the normal state. As the name suggests, sir, the pulp inflammatory condition is reversible. So by definition, reversible pulpitis is a mild to moderate inflammatory condition of the pulp caused by noxious stimuli in which the pulp is capable of returning to the uninflamed state following the removal of the stimuli. That's very important. Whereas in irreversible, simultaneously we'll discuss the difference. Whereas in irreversible, even if you remove the stimuli, the pulp won't be able to return to the uninflamed state within seconds. It might take some time. And when you ask history from the patient may tell that the pain is sharp, lasting but a moment, lasting only for a moment. More often brought on by cold than hot food or beverages and by cold air. Because in this, the caries or the fracture is only started affecting the pulp periphery. And A delta fibers are present in the periphery and C fibers are present in the cores. And when A delta fibers are present in the periphery and these are more sensitive to cold. So in the reversible pulpitis, it is more affected by cold, whereas in irreversible pulpitis, where the inflammatory conditions has gone to the core of the pulp, the patient also will be affected by heat. It does not occur spontaneously and does not continue when the cause has been removed. The diagnosis is mainly by speaking to the patient, the communication with the patient. Whatever history the patient tells, listen to it carefully, ask needed questions, and accordingly come to arrive at a diagnosis. And by doing certain clinical tests, that either radiological investigation or vitality test. The pain is sharp. When you ask the patient may tell all these symptoms. Pain is sharp, lasts but a few seconds, and generally disappears when the stimulus is removed. Cold, sweet, or sore usually causes it. Clinically, you might see something like this. Whenever it is caused by caries, there are other etiological reasons like fractures, crack in the tooth, which might communicate up to the pulp. But most common presentation is a caries, something like this, which is involving the enamel and dentin. The second picture in the radiologically, here you can see the caries, the radiolucencies involving the enamel and mostly only the outer dentin, the DG and the outer dentin. It doesn't invade much into the inner dentin or approximating pulp, which you can see in irreversible pulpitis. You can do vitality test, mostly elicited by the cold test, where when you apply the cold stick, the patient will have sensitivity, but when you remove it immediately within seconds, the patient comes back to the normal stage. Even sometimes it will be affected by heat test, or when you introduce electric test also, the patient will have the sensitivity, but once you remove it, he'll be fine. Histopathologically, if you observe, there will be mild to moderate inflammatory changes with presence of PMNL cells or lymphocytes limited to the area of involved dentinal tubules such as dentinal caries. And when patient comes, prevention is always better than cure. Always try to not cause any caries or fracture or anything to reach up to the pulp. So once it has reached the pulp and patient comes to you with a reversible condition, make sure it doesn't progress into irreversible or other conditions, necrosis. Prevention is better than cure. Periodic care to prevent the development of caries. Early insertion of a restoration if a cavity has already developed. Use of a cavity varnish or cement base before insertion of a filling. When you're doing a restoration, suppose if it is deep, make sure that you're giving a protective base so that the pulp is no more irritated with the restoration. Care in the cavity preparation, polishing are recommended to prevent the pulpitis. The polishing, if at all you're doing, do it with the water or use it intermittently. Now coming to irreversible pulpitis, when we were discussing reversible itself, we have discussed few of the features. Now we'll just quickly go through the different features of irreversible pulpitis. It's a persistent inflammatory condition of the pulp, symptomatic or asymptomatic, caused by noxious stimulus. The pain usually caused by hot or cold stimulus. Both can cause, sometimes relieved by the cold. Pain that occurs spontaneously, it will linger for more than few seconds to minutes or even hours. So lingering pain or spontaneous pain when the patient mentions, then you should be thinking about irreversible pulpitis. The pain is continuous. It may be sharp, piercing or shooting, and it is generally severe. Even when the patient changes the position, that is postural changes when happen, then also pain increases, because when he lies down or bends over, the pulpal pressure increases. So the pain also increases accordingly. Patient may have referred pain. It is maxillary tooth to the temple or sinus region, or mandibular tooth to the ear or neck region. Patients are often kept awake at night. Pain is increased by heat and sometimes relieved by cold, although continued cold may intensify the pain. Apical periodontitis or any inflammatory or other conditions of the periapical region is absent. So mobility or tenderness or percussion usually will be absent. If it goes to that stage, then it will be classified under periapical diseases or periodontal diseases. Clinically, you might see a deep cavity or caries extending up to pulp, or decay under a filling that is close to the pulp. Radiographically, there might be a deep caries or a radiolucency which is close to the pulp, like how you can see in this picture. There is radiolucency involving enamel, dentin close to the pulp, usually involving the inner dentin. Here also you can see, but periapical changes are absent except for this 7, where mild widening of the pedial space you can see in this 7. But otherwise, it will be limited on to the coronal region. No changes will be, significant changes will be seen in the periapical region. Vitality test, whenever you do a vitality test, cold, heat or electric, the pain or sensitivity what the patient will have will linger for a long period of time. Even after you remove the stimulus, the patient will have pain. Sometimes the pulp will be hyper responsive. The results of examination for mobility and percussion and palpation test are negative. Histopathologically, you will see moderate to severe inflammatory condition of the pulp, a zone of infiltration by PMNL leukocytes, and zone of proliferating fibroblasts forming the wall of the lesion where calcific masses may be present. The treatment consists of complete removal of the pulp or pulpectomy or root canal treatment, and the placement of an intracanal medicament to act as a disinfectant or obtundant, such as the newer one we can use newer intracanal medicaments. But there is also one more treatment option. Nowadays, they're analyzing. Suppose if the pulp inflammation is limited to the coronal pulp, partial or total pulpotomy, followed by restoration with MTA or biodentin or other calcium silicate based cements, and restoration is tried. And then follow up to evaluate the symptoms of the patient. If the patient is symptomatic, yes, we have to go ahead with pulpectomy or root canal treatment. If not, this will be sufficient. This is useful especially when the roots are not developed or when open apex is present. Try to preserve the vitality of radicular pulp and then treat only the inflamed pulp in the coronal region. Thank you. We'll discuss the remaining inflammatory conditions in the next session.